Now, the way, just briefly, the way we work is basically we try to stay current in terms of the issues we deal with. So, like now we have a new government, a new health minister, so we try to inform them about how we see the healthcare system. And some of it is even to explain what it means, what the healthcare system means. It comes down to some basics of that. Then we gather almost all relevant data as much as we can, and sometimes it's a colossal investment, like to get the data together on physicians in Israel, which I will tell you in a moment. It took us about 5 years and about 50,000 Israeli shekels just to get the data together. And that has been a colossal and unprecedented investment. And then we try, of course, once we have the data, we analyze them, then we bring together the policymakers and to share the data and establish some policy dialogue with them to share our views of how things may work or may not work. And in fact, one of the major pieces we did over the last year were 2 studies on the Israeli hospital system, in which we actually say before the coronavirus that the system is really not prepared for even regular day, quote unquote, disasters. And we were the only ones who did this kind of study, although the state controller came out with some similar conclusions 2 or 3 months after we came out with it. On the right side, we have basically a closure index developed by Oxford University. And what we did in this analysis, we looked there on the correlation essentially between the closure index and the death rates. And as you can see down on this slide, Israel has been doing relatively well, while unfortunately the UK and Sweden that had very late closures and not as strict as the Israeli closure was, have unfortunately relatively high death rates. And we were the first actually to come out in Israel with this kind of analysis, and we may actually deepen it a little bit in view of the debate that is going on, how much how a tight closure should we have in the future. So this is how we look, relatively speaking, in terms of the war against the coronavirus. Now, in analyzing what has been going on, I look in a very maybe simple, hopefully not too simplistic way on 2 circles. One is Israel as a society, as a culture, as an entity, and the other one is the healthcare system, which is, of course, embedded in the Israeli healthcare system. We have taken the view, and I'll talk more for myself than maybe for others, because this can be a debated view, that Israel has been successful not so much because of its healthcare system, but because of Israel as an entity that basically first and foremost protected the system. So let's go over a few basic facts that relevant facts about Israel that I think were fundamental. Okay, so we have a relatively small land area, okay? Israel is geopolitically virtually an island, okay? It's very hard to penetrate Israel, as you may well know, if you're not welcome. So it's very easy to close the country. We have a very small population. It's a relatively young population, which of course reduces one of the major risk factors that we have. It's not too dense, so it's compared with other countries. So the social distancing was a challenge, but not a major challenge. Standard of living is relatively high. So we know that unfortunately the coronavirus afflicts more low socioeconomic groups for obvious reasons, on which I will not elaborate now. So we have a relatively good standard of living, which helps a lot in these situations. Then the population is relatively in good health in terms of heart and cardiovascular problems. And there is a threat of diabetes. We are, by the way, checking this out right now as part of our work. But otherwise, really risk to the Israeli population has been relatively low. And we cannot ignore the technology issue. We have high-end technology, tracing people with telephone and whatnot that created a lot of political upheaval. Was very effective, and we actually were one of the first countries to introduce it. Then there is what I call, in very broad terms, the Israeli culture. We are used to an emergency footing in regular times. The Mossad, the Home Front Command of the Israeli Defense Forces moved in. They secured supplies in ways that, like the machines and testing equipment and whatnot, in ways which we don't know yet in full. Then the population is very obedient. We are unfortunately getting used to emergency situations. We have missile situations, etc. And some of the required behavior may be quite similar. And then we have, of course, a high solidarity sentiment that counts in these kind of situations. Now let's move to the healthcare system. And here the story is quite different. A basic feature that is very important, I think, especially if I'm to compare it with the United States, and I cannot help it, it's very unfortunate, is that we have universal coverage, in the sense that everybody is entitled to care. There is no question if you have enough coverage, etc. All the issues that can come up in the United States. Universal coverage means a single payer system. I use some common terms used in the United States, or Medicare for all. And it's really a system where everybody is practically entitled to some sort of Medicare. And in many ways, I think it's quite more generous than Medicare regardless. And that has been very important. And that reflects really what I consider the basic solidarity sentiment in Israeli society as it's expressed in its healthcare system. So this, I think, is fundamental. It helps a lot. In other words, people are not worried about having healthcare coverage. This is a very brief sketch of the Israeli healthcare system. I'll try to simplify it and not go into too much detail. Basically, the government, which is the blue segments on top, the government is really the financier of the system. Okay, it's funding what we call the public system. We have a private element too, on which I will not elaborate now. The money goes down basically, and the government, of course, regulates the system. And the money goes down to 4 sickness funds, with whom we had a meeting a week ago, and we'll talk about it a bit later, to 4 sickness funds, which are basically HMOs or plans, which are responsible for delivering the care or securing the care to the population. And these plans or sickness funds or HMOs, they basically procure care from the green segment that you see there at the bottom, from clinics, from hospitals, in many ways. So they may have their own facilities, they may buy facilities, and etc. Buy, I mean, care, etc., from freestanding providers. And that's basically the way the system works. Okay, in the case of the war of this virus, I think the sickness funds have been a bit bypassed, etc. Now, but as far as the health resources go, we have a relatively weak system. Okay, we don't talk about the high skill and commitment of the people and the technology, Israel has a relatively speaking relatively speaking, I want to be very careful, a poor healthcare system in terms of beds per capita, resources per capita. Let me share with you some of the numbers just to get a feel for what I'm talking about. Could you? Yes. So I'll bring up a few numbers. We spend out of the GDP, our pie, basically 7%, compared with about 11, 12% the OECD or European countries spend, and almost 20% spent in the United States. We spend $3,300 per capita, for example, compared with about triple that amount, say, in the United States. And I can go on and on. Then there is something that we have been pointing out very much in our work over the last year or more, is that the Israeli healthcare system has incentives to over-hospitalize. And as a result of that, Israeli hospitals, starting from emergency rooms, have become terribly crowded. And to give you just a feel for one of the numbers, we have an occupancy rate of 94% as opposed to 75% in Europe. So we have not been prepared over the last year even for a simple emergency, nothing of the nature, of course, of the coronavirus. And the other part, and sad derivative of this story, is that community care in Israel, that has been really at the helm of the Israeli healthcare system, has been deteriorating fast because the sickness funds, because of the economic incentives, prefer to send people to hospitals rather to handle them in the community. And this has become, again, very apparent during especially the lockdown, where people were basically afraid to go out to definitely go to hospital, even for regular issues, and didn't have really the required infrastructure to deal with the issues in the community. And that's raised one of the major concerns we pointed out at the very beginning, and that's what we called collateral mortality. In fact, in that study where we said that we believe that the number of beds will not be more than a few hundreds, okay? We also point out that the number of regular deaths because of the war on the virus may actually exceed the number of deaths from the virus. And I still believe that this may be an issue, and that's something we have been trying to point out from the very beginning.
So what are the critical steps or goals in order to fight an epidemic? So control the number of infected people, maintain the health system far from insufficiency, far from collapse, and minimize the hit on economy. These are the three most important goals. So I really want to start by zooming in. And actually, I want to take you with me to the patient bed. Can you imagine what it must feel like for the patient, when physicians and nurses that come to take care of them look like this? And if you can close your eyes and imagine what it must be like to be surrounded by remote control medicine, being watched and supervised by cameras, talking to cameras, no human touch, no eye contact, no reassuring smile. What did physicians and nurses feel? So some of them say that they actually felt as if they were on the moon. The spacesuits they were wearing, they said, were very clumsy. They were hard to put on and even harder to take off, very hard to take care of patients in them, to perform procedures. The lenses become foggy. They also missed the eye contact and human touch. So they also had sense of fear of the unknown, fear of transmitting disease to family members. But on the other hand, they felt that they were taking part in history. So now we can zoom out. So there are almost 8 million known COVID cases in the world today. And there are about 140,000 new cases every day. And the good news is that more than 4 million have recovered already. When we look at the data in different countries, we have to remember a few things. Populations in different countries differ in their average age. They differ in the percent of people that are older than 65 years old. Available and number of tests varies, and the number of tests determines how many positive cases we have. The spread and the quality of modern healthcare is different in different countries. And the reliability and availability of information to the public is also very different in different countries. So unfortunately, the high incidence of morbidity in the Haredi population is a direct result of the disbelief of the Haredi leaders in the steps that the state was taking in the severity of the epidemic, and that resulted in many cases, maybe like in Borough Park in New York. And if I had to put cities next to these lines, so the top line would be Bnei Brak, and the middle line would be Jerusalem, and the other lines would be Tel Aviv, Haifa, and sub-Arab population. I think one of the most important things as far as the Arab population is that the Arab leaders realized very early the severity of the disease, and even though their settlements are and towns are very crowded, they took all necessary measures in order to protect the population, and the numbers reflect their impressive behavior. They closed mosques even before synagogues were closed. I think I have some insights that things can be done a little differently. Management of the crisis was centrally controlled and maybe too centralized. Responsibility was not delegated to mayors and community leaders. The 4 Israeli health funds were not involved enough. Policy of testing is not clear, to say the least. And shutdown policy was national rather than local, based on levels of morbidity. And even though places had very low morbidity, they were still shut down, just like places with high morbidity. That for a long time that took place. It's only at the very end they adjusted it. The health ministry adopted an extreme forecast, and it influenced the measures that were taken. The hospitals were required to prepare hundreds of corona beds each. Thousands of ventilators were ordered. And these things didn't happen. We're very lucky. We're very happy that these things didn't happen. The issue of old folks' homes was attended to too late. I want to talk a little bit about Taub. I knew about Taub, and I enjoyed receiving all the data and the numbers and the figures and the analysis of the situation every year as a CEO of the hospital. And now I'm very happy to take part in part of the activity. I believe that the work of Taub is really very important, first of all, to leaders in various health institutions, but it's really important to help influence the future by studying the present, asking questions, and drawing conclusions and presenting the data and conclusions to high-level influential Israeli authorities. And Dov mentioned it briefly, that just a few days ago, a stimulating Zoom meeting took place with the 4 CEO of the 4 health funds in Israel. And surprisingly, it was the first opportunity for the four of them to discuss and evaluate how each health fund coped with the crisis. And obviously they did different things, and sharing what they did was very important and can help face the future.
Meeting with the last HMOs, first of all, I should say that at least two CEOs of the HMOs are members of our health team. Nisim Aloni of the Laumit Health Fund comes in regularly, and then another one just left the team because she's just too busy, but our interaction with these people is almost on a very concurrent basis. Now, this meeting, what we agreed with them following the meeting, that we are going to put together a joint policy document, okay, Ruth, answering your question, that will propose to the government how best they can use the HMOs in the future. In fact, as Orna mentioned, the whole activity has been too centralized by the health ministry, something that we have been critical for years in other regards, that our health ministry is too centralized. It's really dealing with administrative issues that it shouldn't, etc. And I think one fallout of that was really what I called ignoring the sickness fund, which is turned out to be unbelievable, really. So now we are trying to hopefully be instrumental in rectifying the situation. And I believe that we should have a report in about 2 or 3 weeks based on that meeting and prepared together with the sickness funds. That at least is the understanding.
I think Taub summarized it very nicely. I think that it's amazing. It was amazing for me all along watching it and talking to colleagues that actually it was as if the 4 health funds were left at home. And a lot of the things the government, health ministry tried to do on their own. And it didn't work. It just didn't work.
You basically second-guessed sort of a discussion I had with Susie just the other day. Okay, I mentioned in my talk that we have been terribly concerned about what we call collateral mortality. And one of the causes of collateral mortality may be really what's happening to the economy, and people become unemployed, they lose incomes, In fact, the poverty rate, according to official statistics, increased by 8% just over the last couple of months. Of course, this has tremendous health implications. Now, as Orna said, we don't have data. So what we are trying to do, and I discussed it just, I believe it was yesterday, the other day, Susie, to take whatever available data we have on household expenditure, etc., and we have also a socioeconomic survey, and try basically to extrapolate what might happen to the health of the people, basically starting with food insecurity because of what happens now to incomes, etc. So we are very much concerned with this issue, and this has been actually one of our major lines of work. We did a lot of work on food insecurity in Israel, on food prices, and these issues are very, very, they're very material to what's going on right now. So you definitely have a point, and we try to tackle it with whatever data is available.
I think it's a very good question. The disobedience of us as people can affect the numbers. And I think that if the numbers continue to rise even more dramatically, and if mortality increases, if there are more very sick patients, people might reconsider again and be afraid again. it's hard. It was really a very long period of shutdown. Some of our leaders did not really follow their own instructions, and it affected the people of obedience. I'm sorry to say, but I think after Passover, when people heard what happened in some of our leaders' homes, people were angry, reluctant to continue being obedient. I think right now it might be, it's a little too early to say it's a second wave. Yes, the numbers are higher, but we're not in the rapid increase. If the numbers increase rapidly, I think that Israel will have to take measures. I hope that if the measures have to be taken, that they can be taken in an isolated way, according to morbidity. I don't see a possibility of another total shutdown. It will be terrible for economy. It will be terrible for health also. It will be terrible for so many things. But I hope that the morbidity will enable local decisions and local measures. But time will tell.
It cuts again into one of a major piece of what I consider work we did, and we are trying to modify it a little bit, and that's the intergenerational stress. Okay, that is very important. In other words, if you know, it's in every universal system like the Israeli, you have the young paying for the elderly. Okay, but the burden this time on the young is tremendous. Okay. In other words, and this is something we cannot overlook. I will leave it at that. In other words, and we try to quantify it, and it's a major issue. It will become an increasingly a major issue, and I think it will basically determine what happens in the future. It's one of the reasons we are not going to have another shutdown, etc. Okay.
And I think Orna's right. I don't think there's going to be a general shutdown. I don't think that's going to happen again, because we have much better information now, and therefore you're able to do it a lot smarter than you were in the past. However, the problem I have is, again, mixed signals. So, for instance, for a long time, the government was saying, if you get to 100 cases a day, then we're going to have to start shutting some things down again. Well, we've passed that, but nothing really has been done. And a number of things like that have happened over and over again, where we're just not getting clear information. And when that happens, people start not really believing the information they're getting, and then they start acting accordingly. And that's part of what has gone on. You really need a leadership that's going to stick to their guns and saying, this is what we have to do, and this is what we're doing. And make it very, very clear messaging, and make it very transparent, and make people understand why you're doing what you're doing. That would change the entire picture, in my opinion.